Hi everybody. Tonight I'm going to do the introduction to the nervous system. That would be for the December 10th lecture at 8:40 to 9:30. The material in the book is in chapter 36. Some of this will be a review and some of it will be new, but I thought I'd include the review points to just help freshen your memories. First, I want to review the anatomy and physiology of the nervous system. I know you had this in anatomy and physiology, so it's going to fly by. You probably won't even need to study it or take any notes. The function of the nervous system is to control, direct, and coordinate body function. The nervous system is divided into two major divisions: the central nervous system, which consists of your brain and spinal cord, and the peripheral nervous system, consisting of all the other nerves that go to the periphery or the sides of your body. In other words, the peripheral nervous system are all the nerves outside the center, and the center is the brain and spinal cord. The neuron. The neuron is the functional unit of the nervous system. A neuron consists of a cell body, a nucleus, and dendrites, which receive impulses or information, and an axon, which sends out the information to the next neuron. The nerve impulse is conducted across the synapse by chemicals called neurotransmitters. That's important to know for later in the course. As the unit progresses, you'll learn how malfunctioning neurotransmitters are responsible for specific neurological disorders. And also important to remember, some axons are covered with myelin, causing them to look white. So this is known as the white matter. Unmyelinated axons appear gray. So therefore, they're the gray matter. The central nervous system. The brain is one of the largest organs of the body. It weighs about 3 pounds and is roughly shaped like a mushroom. The brain and spinal cord are covered with a 3-layered tough membrane called the meninges. The meninges have the pia mater, the arachnoid matter, and the dura mater, so 3 layers. The pia mater is the innermost layer that lays next to the brain and spinal cord. The dura mater is the outermost layer next to the skull. Your skull is a rigid, bony structure that is hard and non-flexible, and it protects the brain. The fact that the skull is hard and non-flexible can also become a problem, as you will see later in this lecture when we talk about increased intracranial pressure. The brain is grossly divided into the cerebrum, the cerebellum, and the brainstem. The cerebrum is the frontal part of your brain that's responsible for thinking and consciousness. It's the largest area of the brain and is divided into the right and left hemispheres. The cerebellum is the midsection of the brain, and it controls coordination and balance. The brainstem is your lower brain, and it's responsible for your vital functions, such as heartbeat and breathing. There are 4 hollow ventricles within the brain that make and absorb cerebrospinal fluid, CSF. CSF circulates constantly within the subarachnoid space of the brain and spinal cord. The subarachnoid space is located between the arachnoid and pia mater. And since cerebrospinal fluid acts as a cushion and helps maintain intracranial pressure. Between 125 to 150 mLs of Cerebrospinal fluid is produced daily. The spinal cord is protected by the meninges. The spinal cord exits the brain through the foramen magnum. It's about 17 inches long and 3/4 of an inch thick. The spinal cord is responsible for sending messages to and from the brain. It also sends messages to the peripheral area of the body, and it's a source of many of our reflexes. The peripheral nervous system links the central nervous system to the rest of the body. It consists of 31 spinal nerves and 12 cranial nerves. The autonomic nervous system regulates the body's essential functions. They're things you don't really think about, like your heart rate, peristalsis, sweating, pupil dilation when it gets dark. As you know from previous lectures, the autonomic nervous system is divided into the sympathetic and parasympathetic systems. The neurotransmitters associated with the sympathetic nervous system are epinephrine, norepinephrine, and dopamine. Remember from before, the sympathetic nervous system prepares us for stress, for either fight or flight. It increases your heart rate, your respirations, and makes you more alert. And the parasympathetic nervous system is in control of day-to-day activities. The neurotransmitter associated with the the neurotransmitter associated with the parasympathetic nervous system is acetylcholine. So that's just a quick review of the anatomy. And when we're talking about specific disorders, we'll refer to the parts of the anatomy that they affect. But keep all of that in mind, because it really does become important in understanding the diseases. I'm next going to talk about the assessment, and I'm going to go over diagnostic tests. This also will be a review. One of the diagnostic tests they do for neurogenic disorders are CAT scans with or without contrast. Remember, if that contrast is used, ask about allergies to seafood and iodine. Inform the patient that the contrast dye is going to cause a warm sensation when it is injected, and follow hospital policy as to the length of time, NPO, meds that can be given, etc. An MRI, or magnetic resonance imaging. You know that's a strong magnet that produces an image, and there's no radiation, but it's important to ask about implanted devices. The experience is very frightening if you're claustrophobic, because the tube is very narrow. You need to find out if the patient needs to be medicated for anxiety. Another test is the Cerebral Arteriogram, also called an angiogram. This is an invasive procedure that provides a look at the arteries going to and from the brain. Contrast dye is injected into an artery, and then multiple x-rays are taken as the dye circulates. Explain to the patient they're going to feel a warm sensation or a hot flushing feeling to the neck and head when the dye is introduced. Again, ask about allergies to seafood or iodine. And during the procedure, stay with the patient, monitor the vital signs, neurovital signs. And after the procedure, maintain a pressure dressing and ice to the injection site. A myelogram. A myelogram is a diagnostic test where dye is injected into the spinal canal to make the structure clearly visible with X-ray. The dye is injected through a lumbar puncture, and a warm or burning sensation will probably be felt. Afterwards, monitor the puncture site for leakage of cerebrospinal fluid or bleeding. Inform the patient that the table that they're laying on is going to tilt so the dye can circulate, and monitor the vital signs and the neurovital signs closely. Remember that when contrast dye is used, good hydration is important before and after the exam to help reduce the risk of kidney damage. Make sure the patient voids 8 hours post-test. And again, over and over again, I say it, but always ask the patient about allergies to seafood and iodine. Another test is a spinal tap or a lumbar puncture, where the MD can remove some CSF by inserting a needle into the subarachnoid space below the level of the spinal cord. The pressure within the space can be measured and the fluid is sent to the lab. It's the nurse's responsibility to position the patient, tell the patient to empty their bladder, instruct the patient that during the test to take slow, deep breaths and maintain their position. Monitor vitals, the puncture site, and encourage fluids. As far as CSF goes, or cerebrospinal fluid, normal CFS is clear and colorless, and it contains glucose with a few WBCs, a small amount of protein, and no RBCs. An EEG, that's an electroencephalogram. That's where we put the multiple electrodes onto the scalp and the brain waves are recorded. Remember, it was a test question too, to help patient wash that sticky, horrible electrode paste out of their hair after the test. And then an EMG, or an electromyelography. That's the procedure that measures and records the electrical activity of the muscles and nerves. Mild electrical shocks stimulate the nerves and muscles with small needles placed in the muscle. So the person does have slight discomfort. So that is it for the things I'm going to talk about for the diagnostic tests with the nervous system. Next, I want to talk about the patient history. Obtain a thorough history from the patient or family. Ask about seizures, fainting, dizziness, headache, trauma, surgeries, tingling, difficulty with balance and coordination, any loss of movement, pain, difficulty speaking, hearing, seeing, tasting, and smelling. Also ask about sleep and memory problems. Get a list of meds and allergies. In addition, inquire if there's a history of other disorders like diabetes, stroke, high blood pressure, or mental illness. Ask about diet, alcohol, and tobacco use. Now, because you're really focused on the neurological aspect of the assessment, during the interview, be very aware of the level of consciousness, the alertness, the orientation, the speech, and the movement of the person you're interviewing. During the interview and assessment, take into account any hard of hearing, visual impairments, and always remember the normal changes of aging that could affect your assessment. Next, we'll go to the neurophysical assessment. So the neurophysical assessment is going to assess the patient's posture, movement, and appearance. You'll determine if the patient can see and hear. Assess for hearing with the whisper test. So if I whisper and you can hear me, you've passed the whisper test. And the Rhine-Weber test, that's in your book. And the Snellen chart for vision. We'll discuss hearing loss and vision loss in another unit during med-surg, so you don't need to go into those now. Get the neurovital signs and regular vital signs. Make sure to take the blood pressure in both arms. And assess the cranial nerves and motor and sensory function. The cranial nerves. This could be a whole lecture in itself, is assessing the cranial nerves. There's a series of tests that can be done to test cranial nerve function. I'm not going to go into great detail, but these tests are very interesting and give important clues as to neurological functioning. For example, to test the olfactory nerve, that's the nerve of smell, nerve number 1, you'd gather items with distinctive smells, such as coffee or chocolate. Pass one item at a time under each nostril and have the person ID the item with their eyes covered. The cranial nerve tests are fun tests to do in lab or with each other, so you may want to look them up. They can be very interesting. Motor function. In general, assess for motor function by assessing the upper and lower extremities for weakness, atrophy, and trauma. Identify increased muscle activity or spasticity, or decreased muscle activity or flaccicity. Assess the gait and the use of assisted devices. In other words, if they're using a cane or a walker, are they using it properly? Is it safe? Is their balance adequate? Things like that. The level of consciousness, or the LOC. Consciousness means being oriented to time, place, and person, and responding appropriately to external stimuli. Your level of consciousness can be altered by increased intracranial pressure and cerebral edema, because increased pressure is going to reduce the blood supply to the brain. Any condition that reduces oxygen and glucose to the brain is going to alter your level of consciousness. So, you can be fully conscious. That means you're alert and oriented to person, place, time, and situation. You can be, number 2, confused. You may be disoriented to time, place, or person, or situation. Have a short attention span and a poor memory. Delirium. Delirium is motor restlessness, irritability, agitation. The delirious person may hallucinate and become combative. You'll see people in this state, such as the person that's withdrawing from alcohol or substance abuse. Sometimes elderly people go into delirium with UTIs. The next level of consciousness is obtundation. In this state, the person is drowsy and lethargic and responds to stimuli, but they quickly fall back asleep. Stupor. This patient is generally unresponsive, but responds to painful stimuli. So if you gently prick them with the pin, they would respond. Semi-comatose. This person responds to pain only by reflexive movement. They're not responding to coil back from the pain. It's probably reflexive. The patient at this point is posturing, most likely, and they'd probably respond to pain by going into the decorticate or decerebrate posture. Coma, there's no response. The patient is probably in the flaccid position, so they're just flaccid like a rag doll. I will go over the posturing in a few minutes. So just to lighten the mood a little bit, how is your level of consciousness at this point in the lecture? Hopefully most of you are fully conscious. However, your memory and attention spans may be a bit compromised. I hope none of you are obtunded yet. Just a little of my attempt at humor. Remember the Glasgow Coma scale? I will put a a copy of it in the back of this packet. The Glasgow Coma Scale is a quick guide to assess someone's level of consciousness. The lower the patient scores, the worse the condition. It's going to measure your eye-opening response, your best verbal response, and your best motor response. So if you look at the chart, spontaneous eye-opening scores 4 points. Alert and oriented times 3, or it should be 4, scores 5 points. Obeying commands to move scores 6, and so forth. On the opposite end of the scale, no eye-opening only gets 1 point, no verbal response 1, and so forth. A score of 15 means the patient is fully conscious. 14 to 19 points means the patient is compromised, somewhere in the level between confusion and stupor. And a score of 8 or less indicates coma. And of course, if the patient is totally unresponsive, they will have a score of 3. A score of 3 is as bad as it can get. So now let's talk about those postures that I was saying. And they are pictures in the book, and I did include pictures in the outline. Posturing is another way of determining neurological response and the gravity of increased intracranial pressure. Posturing occurs late. Remember these terms and be able to differentiate between them. Decorticate posturing. The problem is at the level of the brain stem. The patient does not respond to painful stimuli. If painful stimuli is applied, the patient remains rigid and still, with their arms flexed across their chest and their fists clenched and their legs extended. So if you look at that picture, you can see what I mean. Decerebrate posturing is even worse than decorticate posturing. It's a grave sign. It indicates the brain has probably herniated. So what happens is the brain herniates or pushes out of the brain stem. The extremities remain stiff and extended with the fist clenched when painful stimuli is applied. And then the flaccid posturing, the patient just remains flaccid like a rag doll, with no response to anything. This indicates brain death. Neurovital signs. An important and critical part of the neurological assessment is checking the neurovital signs. We did do this in lab. Neurovital signs or a neurocheck is part of an ongoing assessment of a patient with a neurological impairment or a patient with the possibility of getting a neurological impairment. A neurocheck is done to detect subtle changes early enough to allow for medical intervention. It should be done at specific intervals based on the patient's condition and agency policy. For example, for a newly admitted patient, you may plan to assess neurovital signs every 15 minutes times 4, move up to 30 minutes times 4, then every hour times 2, then every 2 hours times 1, and so forth and so on. This is a fairly common plan, but the frequency of the assessment is based on the severity of the problem. Remember, a neurocheck is very different from a neuroexam. A neuroexam is more extensive. It includes checking reflexes, cranial nerve function, memory, judgment, and thinking ability. Although the nurse may be able to ascertain some of these things during their assessment, a neuroexam is done by the doctor or the physician's assistant. A neurocheck is a tool used to assess the patient's condition quickly and is done by the nurse. Neurochecks really can assess a change in a person's level of conscious and mental status quickly so that help can be found. So the nurse's role is to detect and report any deterioration in the patient's condition immediately. That's why it's very important to know your patient's baseline. What was the patient's status when they arrived at the hospital? Use all of your communication skills, listen and read. Read the doctor's admission note, the nursing assessment, and any recent notes. The 4 major components of neurovital signs or a neurocheck are the level of consciousness, the pupillary reflexes and reactions, neuromuscular activity or motor function, vital signs, TPR, blood pressure, and oxygen. Your level of consciousness is your state of awareness. Level of consciousness is often the most sensitive indication of neurofunction, and therefore you will see changes here first and early. Because we are looking to see if the patient is alert and oriented ×3, we see these things rapidly. Are they alert, obtunded, stuporous, semi-comatose, comatose? So remember alert. Alert means you're awake and oriented to person, place, time, and situation, and you respond appropriately to all stimuli. If a person becomes disoriented, they tend to lose time first. So they would be disoriented to time. They lose orientation to place second, and then to person in that order. Always ask the person what the date is, what's the month, what's the year, what's the season, where are you, what kind of place is this, who's the president, what's your husband's name, etc. If you're lethargic, you sleep often, you're easily arousable, you respond slowly but appropriately. Obtunded, we went over, you're aroused by shaking or shouting, but you quickly return back to sleep. Stuporous, you respond to pain only with purposeful movements. Semi-comatose responds to pain only with reflexive movements and goes into the cerebral or decorticate posturing. Decorticate posturing means there's damage to the cortex, decerebrate damage to the midbrain or pons. So the lower it goes in your brain, the worse the condition. Comatose, there's no response, no reflexes, and the person has flaccid muscle tone. It's important to remember that using words such as we just talked about can be ambiguous because definitions vary from facility to facility, and it's a little subjective. Understand what these words mean, but it's best to describe the patient's condition objectively in your own words, instead of saying the person is in the decorticate posture. Describe that they're laying flat, their fists are clenched, etc. The pupillary reflexes in reaction, that's PERLA. We use our pen light flashlight. So P is for pupils, E is for equal, R is for round, R is for reactive to light, L is to light, and A is accommodation. PERLA is checked by looking at the pupils, the size, the shape, the equality, and their reaction to light. Changes in any of these components may signal an emergency and must be reported immediately. Look at the pupil size of both eyes in normal light. Normally each pupil is 2 to 6 millimeters and should be round, equal in size. However, some people may normally have unequal pupils. That's another reason it's important to know the person's baseline. Also be aware that previous surgery may alter the shape of the pupil. Check for reaction to light. Darken the room. Bring the pen light up and from the side until it shines on the pupil. You want to see brisk, equal constriction of both eyes or both pupils. To check accommodation, which is how the pupil accommodates to near and far, have the patient focus on an object far away and then focus on your finger about 4 inches from his nose. If the pupils accommodate, they should constrict when they see your finger. Be also aware that what the meds the person is on can make changes in your pupils. Meds such as morphine cause the pupils to constrict, whereas atropine causes the pupils to dilate. Motor function. A bedside neuro check includes an evaluation of motor function. Check all 4 extremities bilaterally to evaluate grip strength and strength to resist pressure. Have the patient flex and extend his arm against your hand. Have them squeeze your finger. Ask the person to lift the leg while you press against it. Have them flex and extend each foot against your hand as you apply pressure at the sole of the foot. Note the strength of each test on each limb. So these are your grips and pushes. The dominant hand may be a bit stronger than the non-dominant hand normally. And the following scale is an example of how you would score motor function. 0 being no movement, 1 contraction only, and then we move up to number 5 where they lift with full resistance. Also, you want to check the Babinski reflex by stroking the bottom of the foot. If you can see in the picture I put in the outline. If the big toe flexes upward and the other toes fan out, this is an indication of a neurological motor disorder. So try that on yourself when you're home. Vital signs, TPR, blood pressure and oxygen sats are part of the neurovital signs. Temperature changes can occur with brain damage, especially elevated temperature. Note the pulse rate, rhythm, and volume. Count respirations, and always remember to look for rate, rhythm, and depth. Take the blood pressure in the same arm every time for consistency. Make sure you know the baselines. Certain abnormalities and vital signs may indicate damage to certain parts of the brain. The brainstem regulates vital signs. Changes in vital signs should be reported immediately, particularly changes indicating increased intracranial pressure, which we are going to talk about next. So that's a good segue into increased intracranial pressure. Let's take a little break, and I'll come back and we'll do increased intracranial pressure. Increased intracranial pressure occurs when there's an increase in the volume of the contents within the cranium. Remember, the brain or cranium can only expand slightly because it is encased in the bony inflexible skull. Thus, any increase in brain volume, which I mean by that brain swelling, causes increased intracranial pressure. At first, the brain tries to compensate for the rising pressure by vein constricting and displacing the cerebrospinal fluid. But as the pressure rises, these compensating mechanisms fail and blood flow to the brain decreases. So the brain thinks that didn't work when I had vasoconstriction. So now I'm going to try to compensate by vasodilation. At the same time, there is cerebral edema due to chemical changes that are trying to alter the problem. As a result, there is even greater intracranial pressure. When the pressure rises to a critical level, the only escape is downward. So the brain goes downward and herniates out of the cavity. So this is going to be fatal. There is no room for the swollen brain within the hard bony skull, so it herniates through the foramen magnum. So herniation is the pressure rises, the brain is pushed through the foramen magnum, which compresses the brain stem. So the vital signs stop. The brain stem herniates out of the skull. So what conditions can cause increased intracranial pressure? The first would be a head injury. Head trauma causes more deaths than any other neurological condition in people under the age of 50. Traffic accidents are the leading cause of death in males under the age of 35. Head injuries include scalp lacerations, skull fractures, concussions, contusions, and hematomas. A concussion is a brain injury due to violent shaking of the brain. That's what happens in shaken baby syndrome, football injuries, motor vehicle accidents. A contusion is a more serious brain injury leading to bruising of the brain due to blunt trauma. And a hematoma is the collection of blood. Another cause of increased intracranial pressure is brain tumors. Also, a third reason is brain and spinal cord infections such as meningitis that we're going to talk about next week. And fourth, a stroke or a cerebrovascular accident. The Valsalva Maneuver causes increased intracranial pressure in everyone, but under normal circumstances, the pressure returns to normal after the activity ceases. So it occurs, the Valsalva Maneuver occurs when you try to forcibly exhale with the glottis, nose, and mouth closed. So try it. 5 activities that cause this are sneezing, coughing, vomiting, straining to have a bowel movement, and bending forward. So briefly during those times, your intracranial pressure will increase. But of course, that's normal and the person will have no ill effects. The signs and symptoms of increased intracranial pressure. Any increase in intracranial pressure causes changes in the patient's level of consciousness, pupil response, motor function, speech, and vital signs. These manifestations may develop rapidly or slowly. They may be dramatic or subtle. It all depends on the location and cause of the increase in intracranial pressure. The nurse needs to be diligent and monitor the patient closely for subtle changes. The changes worsen and become more dramatic as the pressure increases. Remember what we said before, changes in the level of consciousness are usually the earliest sign of increased intracranial pressure. It is important for you to be able to recognize the signs and symptoms of intracranial pressure because early intervention is essential for life. On the next pages, I put a chart kind of to compare and contrast early with late. So, level of consciousness, this page. Level of consciousness, an early increased intracranial pressure the person is irritable, restless, and disoriented to time, and then if it gets worse, then to place and person. The personality changes, the person's confused and has trouble with their short-term memory. Late and increased intracranial pressure, level of consciousness decreases as the intracranial pressure increases, eventually leading to coma and no response to painful stimuli. The motor functioning early in intracranial pressure, the person has weakness in one extremity, progressing to hemiplegia or paralysis on the side opposite where the injury occurred. So if I'm injured on this side of my brain, I would have the hemiplegia on this side. Now this is early intracranial pressure. Late intracranial pressure, increased intracranial pressure, the motor functioning show posturing. And remember the posturing, the first is decorticate, second is just cerebrate, and lastly flaccid posturism, with each one getting more grave than the next. Early in intracranial pressure, the pupils are equal and reactive to light. Pupils, as the intracranial pressure increases, the pupils react more slowly and sluggishly. Eventually, the pupils only react ipsilaterally. That's a great word, ipsilaterally, right? So ipsilaterally means that one pupil reacts and the other pupil remains fixed and dilated and appears larger than the other eye. Finally, both pupils will be fixed and dilated. Your vision, early on with increased intracranial pressure, there's blurred vision or double vision. And then late in increased intracranial pressure, you can't assess the vision because of their compromised level of consciousness. Early in intracranial pressure, the speech is slurred and the person has difficulty speaking. Late in increased intracranial pressure, they cannot speak because they're so compromised. The blood pressure. Early on, the blood pressure is elevated. Late in increased intracranial pressure, you have what we call Cushing's response. This systolic blood pressure continues to rise, but not the diastolic pressure. This results in a widening and continually widening pulse pressure. So the systolic is going up, but not the diastolic, and you'll see the pulse pressure becomes larger and larger. Bradycardia occurs, the heart rate is probably below 60, and then Cushing's response, which is a grave sign. Report as soon as possible. The pulse is slightly elevated in the beginning when the intracranial pressure starts to rise. Later, in increased intracranial pressure, the person has bradycardia, a heart rate below 60. The respirations depend on the site of your injury and the amount of damage and the amount of brainstem compression. That's early on. Later, the respirations decrease and become irregular. Deteriorating neurological function is going to lead to hypoxia. The patient is going to be on continuous oxygen because hypoxia is going to cause the intracranial pressure to rise even more. And very late in increased intracranial pressure, Cheyne-Stokes respirations take over. That's those cyclic breathing patterns. So you have your period of apnea that lasts about 10 to 60 seconds, followed by an increased rate and depth of respirations, and then a slowing of respirations, and then apnea. The temperature, in the beginning, the temperature isn't too indicative. It could be high or it could be low. But in late intracranial pressure, the temperature is markedly elevated. Other things you notice, early on with intracranial pressure, the person may have a headache that's worse in the morning or when they change positions. Later, with intracranial pressure, the headache is continuous. The person has projectile viling. They have loss of pupil, cornea, gag, and swallowing reflexes. The interdisciplinary care and nursing responsibility when taking care of somebody with increased intracranial pressure. Diagnostic tests. The doctor's going to order specific diagnostic tests. So you want to remember, though, that a lumbar puncture is done with caution with increased intracranial pressure because it greatly increases the risk of the brain herniating. Please review the diagnostic tests and the nurse's responsibilities. Medications. You don't need to really memorize these. I just want to make you familiar with some of them. They're given to help relieve increased intracranial pressure and to treat the signs and symptoms. Osmotic diuretics, such as mannitol, are given to help draw water out of the edematous brain so it can be excreted by the kidneys. If someone is on mannitol, they should be monitored closely for dehydration and electrolyte loss. Loop diuretics are also given. Corticosteroids like prednisone are given to help reduce the brain inflammation. Anticonvulsants, and we'll talk about these drugs when we do seizures, but those are given to prevent and control seizures. Antipyretics are given to reduce the temperature. Stool softeners like Colace are given to help reduce straining during a bowel movement. That would be the Valsalva Maneuver, and this does increase intracranial pressure, so you don't want to increase it more. Barbiturates like phenobarbital may be used to place a patient in a medically induced coma to reduce the patient's metabolic rate and allow the brain time to heal. It is the nurse's responsibility to administer the meds and always be cognizant of the side effects and special instructions. Intracranial pressure monitoring. It's not something you'll probably be using, but just so you're familiar with it. It's a device or probe is inserted into the skull to assess for increased intracranial pressure. Normal intracranial pressure is 0 to 10 mm's. A pressure increase to 20 mm's indicates brain compression, which may lead to herniation. You're probably not going to see these devices because ICP monitoring devices are used only in the critical care unit. Because it is an invasive procedure, the client needs to be closely monitored by a skilled practitioner. Surgery can be done to relieve the intracranial pressure. One is a bone flap. So literally a flap of bone is removed from the scalp to give the brain room to expand. So once the whole piece of that bony skull is removed, and the other thing is burr holes where they drill holes into the skull to remove blood clots and hematomas. Airway and breathing. As intracranial pressure increases, it impedes the brainstem. Remember, the brainstem controls your respirations. You have to monitor respiration depth and rhythm closely. And the patient will always be on oxygen because hypoxia is going to increase the intracranial pressure. Assess the patient's ability to clear secretions. Always have suction equipment and oral airway at the bedside. If you suction someone with increased intracranial pressure, only do it for 10 seconds or less, because when you suction someone, it reduces the oxygen, and that increases intracranial pressure. Position the person in the side-lying position to prevent the tongue from obstructing the airway. Turn the patient frequently to prevent secretions from pooling in one area of the lung. Monitor the airway closely as the intracranial pressure increases. Check oxygen sats frequently. Make sure your oxygen tubing is patent. Again, hypoxia increases intracranial pressure, and the brain's going to need a constant supply of oxygen to avoid permanent damage. You'll monitor the ABCs, or the arterial blood gases. Increased CO2 causes vasodilation, and that also increases intracranial pressure. Provide regular mouth care. Keep the lips and mucous membranes moist for the patient's comfort, and also so the dried up secretions are not swallowed, which could lead to aspiration. Hyperthermia. Remember when we went over the signs and symptoms of late intracranial pressure, said that the temperature and late intracranial pressure is usually very high. So as intracranial pressure increases, so does your temperature. Monitor the temperature at least every 2 hours. Don't use rectal thermometers because that can also increase intracranial pressure. And oral temps are definitely a problem. It could be a safety risk because if the person had a seizure. But the temperature may get so high that the patient may need a hyperthermia blanket. Seizures. Patients with increased intracranial pressure are prone to seizures. Seizure precautions should be in place, like padded side rails, and we'll talk about those when we do the seizure lecture. Skin immobility and skin breakdown are another issue. So make sure you turn the patient, lift them rather than dragging them. Provide good skin care, keep them clean and dry, the sheets wrinkle-free. Position them in ways to decrease contracture and use range of motion exercises. Nutrition and fluids. Head injuries are going to increase a person's metabolism, which puts them at risk for malnutrition. Tube feedings, or TPN, will be ordered to prevent malnutrition. And you know they can be administered via a nasogastric tube or gastrostomy tube. Prior to feeding, remember to check for placement to avoid aspiration. And always monitor the person's glucose level carefully when they're on TPN. Often, when a person's on TPN, they are on insulin even though they're not diabetic because the formula causes their blood sugar to rise. Fluids will be given to maintain fluid and electrolyte balance and to administer medication. Only normal saline and lactated ringers are given because they do not cross the blood-brain barrier. They're infused very slowly at 50 to 75 mLs per hour to avoid fluid overload. and fluids are restricted to avoid increased intracranial pressure. A Foley catheter will be in place. The person is going to be on strict hourly intake and output and daily weights. You want to assess the person for cerebrospinal fluid leakage. Test the drainage from the ears or the nose with a glucose strip. Clear drainage that tests positive for glucose indicates CSF, and also monitor for signs and symptoms of infection. Keep the ears and nose clean, or that they are ports of entry for infection. Sterile cotton is placed in the ear, and a 4x4 is taped under the nose to collect the drainage. We call that a mustache dressing. If the patient is alert, teach him never to stop a sneeze. This can force bacteria from the nose into the brain. And use strict aseptic technique when changing dressings or handling an ICP device, of course. Pain. Pain is difficult to assess, and it's difficult to manage with head injuries. Although pain does increase intracranial pressure, pain meds alter level of consciousness and vital signs. For example, morphine is going to suppress respirations, and the respirations may also be compromised, and the respirations may already be compromised because of the increased intracranial pressure on the brainstem. Pain medication is used with caution. Always assess vital signs prior to giving pain meds, and call the doctor if you have any concerns. If you are uncomfortable, you do not have to give the med, but always report. Make sure you check the neurovital signs and report even subtle changes immediately, because this could be an important sign that will help to save a person's life with rapid intervention. Other nursing measures: keep the environment calm and quiet, reduce noise and dim the lights, always speak softly and calmly. Pace your nursing activities over the course of the shift. Loud noises, bright lights, and constant nursing care not only prevent the patient from resting, they increase the intracranial pressure. Don't let the patient detecting anxiety from you, because if they see you're anxious, that's going to increase their anxiety, and anxiety causes intracranial pressure to rise. Turn the patient slowly and gently with a draw sheet. Lift, don't drag him, because sudden movement increases intracranial pressure. Elevate the head of the bed 30 degrees and keep the head in the midline position. This helps promote venous drainage from the head. And avoid flexing the head and hips, because that increases intracranial pressure. Briefly, I'll just mention increased intracranial pressure in children. It's in your PD book. The risk of head injury in children is high. Some common causes of increased intracranial pressure in children include shaken baby syndrome and not using a seatbelt. Rise syndrome caused by treating under 12 with aspirin during a viral infection also causes brain trauma, which can increase intracranial pressure. If the fontanelles are open as they are with an infant, there is a higher tolerance for increased intracranial pressure, as the brain has more room to expand. The young child's lack of ability to communicate and cooperate may pose a challenge during neurological monitoring. The response of a child to a head injury may differ from those of an adult. Responses should be correlated to the child's developmental age, and there is a modified Glasgow Coma scale for infants, and I put it in your packet. on the last page. For infants, occipital circumference of the head is monitored. Also monitor tension on the fontanelles in the presence of a high-pitched cry, which is a grave sign in an infant. Remember, report and document. As we go along, you'll see that the nervous system can be affected by multiple disorders for numerous reasons. It can be complicated but also fascinating. Don't get discouraged by the new concepts and terminology. It's all going to fall into place as you listen, read, and review. Good night, everybody.